So in the last lecture, we looked at the axial skeleton, and in this one, we'll pick up the appendicular skeleton. So that's going to be basically everything that's not attached to the head, spine, or trunk. So we'll talk about the shoulder, girdle, and the upper extremities, and the pelvis and the lower extremities. Just showing you the different bones that we'll be looking at and how many of them there are. Hopefully some of you know who this guy is. This is Aaron Rodgers, the most accurate quarterback ever in the history of the NFL. Currently plays for the Green Bay Packers, but a couple of years ago, he had a serious injury to his shoulder. He was being tackled and kind of landed down on that right shoulder. And as a result, he fractured his clavicle. And so this is part of that appendicular skeleton that we're talking about. In fact, the clavicle is the bone that really attaches the limbs to the axial skeleton. And we'll see that here in a minute. So if we start looking at the shoulder girdle, which is the part of the body that Aaron Rodgers fractured, we can see that it's composed of really just a couple of bones, but then there's numerous muscles and ligaments. And we'll talk about the muscles when we get to the muscle chapter, and we'll talk a little bit about the ligaments when we get to the joint lecture, which will be after the skeletal system, or the end of the skeletal system. We'll talk about joints. So for now, we're going to focus on the bones. So the scapula, which is, this bone here, is actually articulates with two different bones. So there's actually two joints formed by the scapula. One, which we'll discuss here, is this joint in between the scapula and the clavicle, which is here. So in between those two bones right there, let's see if I can get a different color here. Right here is the acromioclavicular joint, or what we commonly call the AC joint. So that's one, but it also articulates here with the head of the humerus, and that's called the glenohumeral joint. And that's what we would typically talk about when we talk about the shoulder. For example, if someone says my shoulder was dislocated, what they mean is the head of the humerus has come out of the glenohumeral joint, has kind of popped out of its articulation with the scapula. Interestingly, when we talk about a shoulder separation, if you've ever heard, often it's like a football player, somebody, again, who landed on their shoulder. Sometimes weightlifters will get a shoulder separation. We're actually talking about this joint. The AC joint is actually the joint that is disrupted in a shoulder separation. So the clavicle then articulates with the scapula at the AC joint, as we mentioned, and then it also articulates with the axial skeleton at the sternum. And so it's actually the clavicle that bears a lot of the weight of the arm. It actually kind of transfers the weight of the arm to the sternum, so that that central axial skeleton can carry some of the weight of the arm. So it's really the bone that attaches the appendicular skeleton to the axial skeleton in the upper extremities. So if we look at the clavicle, there's just a few identifying parts on the clavicle that you'll have to learn. There's an acromial end, so that's the end that's going to articulate with the shoulder. And then there's the sternal end, so the sternal end is obviously going to articulate with the sternum. There is a, let's see, maybe it's not showing it on this picture. Yeah, not really. So you should be able to tell the difference between the acromial end and the sternal end. You see the acromial end is a bit fatter. This sternal end is kind of like a trapezoid almost, but the acromial end has a kind of a wider area and has that bump there. That's how you'll be able to tell which side is articulating with the sternum and which side is articulating with the scapula. So depending on how you move the shoulder, the clavicle will either move up or move back or move forward. So this picture here is trying to show you kind of a top down. If you kind of went to your neighbor and just looked down, stood on your tippy toes and looked down over their shoulder, what would you see? So this would be the top of the clavicle articulating with the sternum, and then this would be that AC joint that we talked about. And over here, you can't really see it, but this would be the humerus, the arm, going down there. So you're kind of looking from the top down. So depending on how you move the shoulder, that clavicle can move in multiple directions. So if you kind of stand up straight and pull your shoulders back, if you're trying, for example, to have good posture, you would call that retraction of the shoulder. And you can see that the clavicle moves backwards. You could also have protraction of the shoulder, which would be if you kind of hunch your shoulders forward. That would be protraction. So the kind of forward and backward motion is protraction and retraction. But then you can also lift your shoulders up as if you're like when you're shrugging your shoulders, and that would be elevation of the shoulder girdle. Or you could have depression where you kind of pull your shoulders down at your side, and that would be depression. So elevation and depression would be the kind of superior to inferior movement, and protraction, retraction would be the anterior, posterior movement. Make sure you're comfortable with those terms. If we look at the scapula now in a bit more detail, you're going to see there's actually a lot of parts on the scapula that you have to learn. Let's just start by talking about the borders, because most of these will be self-explanatory. If we're looking here at an anterior view, so this would be if you're looking straight on, like you have the picture here, and you're looking straight on from the front at the scapula. So if you removed the ribs, and you could see the whole scapula because the scapula sits posterior, this is what you would see. So if we look at the edges or the borders, I think that's an easy place to start. So you have a superior border, and you have a lateral border, and you have a medial border. So I think those are easy enough to understand and to remember. Then you have two angles, or two, you could almost think of two curved areas. So the angle on the bottom is the inferior angle. The angle at the top here would be the superior angle. And then you have a lateral angle would be this part of the scapula. So you have three edges or three borders, and you have three angles: lateral, superior, and inferior. Then the rest of the clavicle is the body of the clavicle. The acromion we already talked about. That was, remember that the AC was the acromioclavicular joint, so it's where the acromion meets the clavicle. We'll see the acromion better on the posterior and the lateral view. But on the anterior view, you can also see another projection here coming off of the scapula. And that's the coracoid process. You'll need to know that part as well. And then you can see some depressions we'll see as we go along looking at the scapula of where some of the muscles of the rotator cuff lay against the bone. So for example, this area here is the subscapular fossa. Remember, fossa just kind of means a shallow depression. Okay, if we look at the lateral view of the scapula, so this would be kind of looking at somebody's shoulder from the side, and you took the humerus out so that you could just see the shoulder. The part where the humerus inserts to make the shoulder joint, or the glenohumeral joint, that's called the glenoid cavity. So glenohumeral comes from those two terms, glenoid cavity and the head of the humerus. That's the glenohumeral joint. That's the shoulder joint. You can see the acromion now much better here. You can still see the coracoid process that we mentioned. And there's another structure that we'll see posteriorly, but you can see here laterally as well, called the spine. And then there's the lateral border that we already talked about, the inferior angle we already talked about. So if you turn the scapula over, or you look at someone's scapula from behind, from their back, this is what you would see. And the thing that's most prominent, I think, posteriorly is this spine running across the back. So if I were you, if someone showed me a scapula, the first thing I would do is ask myself, am I looking at an anterior view or a posterior view? And the way that you'll know is whether or not this spine is running across at an angle in the upper part of the bone. If you can see that spine running across, then you know you're looking posteriorly. If there's no spine visible, then you know you're looking anteriorly. Once you've oriented yourself to anterior or posterior view, now you should be able to figure out what else you're looking at. So because you're looking at the back, so you're looking at this view, this side becomes the medial border, this side is the lateral border, there's that inferior angle again, there would be the superior angle again. You've got your superior border, there's the coracoid from behind, there's the acromion from behind. Okay, if we continue out, so we looked at clavicle, scapula, now we're going to start looking at the upper extremity, starting with the humerus, which is the largest bone in your arm, and it's the bone that attaches to the shoulder, attaches to the scapula at the glenoid cavity to form the glenohumeral joint. And you can see here again, we're going to see several parts. So over here is kind of showing you the big picture, but we're going to break it up into kind of the superior half and the inferior half. So if we look at the bigger picture over here, let's look at the superior half of the humerus. So if you just look at the top part, we're going to call that top part the head. So the head is kind of this rounded area. That would be the head of the humerus, and that's the part that fits in the glenoid cavity. If you kind of go lateral to the head, because the head's going to be medial and inside that glenoid cavity, you can see there are two tubercles. One is smaller and one is bigger. The smaller one is going to be called the lesser tubercle, and the bigger one is going to be called the greater tubercle. So these are just kind of bony projections, and when you guys get in the lab, you'll be able to feel these sticking out from the bone, and you'll be able to see them quite easily. So just like our head, if you kind of went inferior to our head, the next structure that you would find would be the neck. So the same thing here in the humerus, and we're going to see the same thing in the femur later. As you go down from the head, you reach what's called the neck. Now, what's interesting here about the humerus is there's actually two necks. The one that I think is easier to see is down here, and that's called the surgical neck. And the reason it's called the surgical neck is because that's where most fractures happen. And so that's often where the surgeon is working to fix the humerus when it's been broken. So we give that the term surgical neck. There is actually an anatomical neck, and I'm going to blow up this picture here since I've written on the other side. The anatomical neck is going to be in between the head and those two tubercles that we talked about. So remember, there's a greater and a lesser tubercle, and we said there was the head. So the anatomical neck is going to run right in between those. So that's the anatomical neck. The surgical neck is going to be here just below those tubercles. That's the surgical neck. If you kind of came down from the head and the neck area, the most of the bone is going to be called the shaft. That's the body of the bone. But as we move down, we're going to move to the slide and see kind of an inferior view. So we're going to still have the shaft kind of working its way down. And then as we get down to the bottom of the humerus, we're going to find some more structures that will be important to remember. Now, a couple of them are just points of articulation between the humerus and the bones of the forearm, which are called the radius and the ulna. And so the radius and the ulna have to make the elbow joint with the humerus. So there has to be a place for those bones to fit. And that's here, the coronoid fossa and the radial fossa are going to be where the radius bone and a portion of the ulna articulate with the humerus to form the elbow. So we'll see those parts of the radius and ulna here soon. Radial fossa is going to be easy to remember. That's where the radius articulates, obviously. Coronoid fossa is going to be a little bit more difficult to remember, but that's where the ulna articulates, and we'll see because there's a part of the ulna called the coronoid process that fits in the coronoid fossa. Two other things to notice here would be a medial epicondyle and a lateral epicondyle. So the condyle is this area here. So epi means above. So these areas are just above the condyle. That's why they're called epicondyles. And actually these two, medial epicondyle and lateral epicondyle, clinically speaking, are probably more important than the condyle itself. So there are rarely problems with the condyle, but there are frequently problems at the area of the medial epicondyle or the lateral epicondyle. So people who have pain at the medial epicondyle, they're not actually having pain of the bone, they're having pain of the tendons that attach muscles right to that area of the bone. So when you press over that area of the bone, it hurts. So medial is obviously going to be medial elbow or inner elbow in the anatomical position. So if you have tenderness and pain in that area, that's what we call golfer's elbow. Maybe you've heard of that. And it's funny, we call it golfer's elbow. A lot of pitchers, baseball pitchers, also get tendinitis there on the medial side, and we call that medial epicondylitis, right? Epicondyle, and you add itis for inflammation, epicondylitis. Okay, there's also lateral epicondylitis at the lateral epicondyle. If those tendons that attach to that part of the bone become inflamed, and we tend to call that, the common term is tennis elbow, although you don't have to play tennis to get it. Other things can do it as well, but that is the common place for tennis players to have pain. So on the lateral epicondyle, you have lateral epicondylitis or tennis elbow, and on the medial epicondyle, you have golfer's elbow. Okay, if we kept going south there, you find the condyle, and the condyle is broken up into two parts, the trochleum and the capitulum. So the trochlea is going to be basically this. It kind of looks like a pulley with a little groove there in the middle. And then the capitulum is on what's left over. And you guys will see that again in the lab as you touch the bones. You'll be able to see those two parts. Okay, so something that you're going to have to get used to when you're looking at bones, and the same thing with sometimes with views of muscle, is you're going to want to know what view of the bone am I looking at. So just as we were talking about with the scapula, same thing is going to be true here with each bone we look at. Am I looking at an anterior view? What can I see? Or am I looking at a posterior view? Or am I looking at a lateral view? Because you're gonna notice that different structures are visible only in one view, or maybe they're visible better in a particular view, or maybe they look a little bit different depending on what view you're looking at. So we've been looking at the anterior view of the humerus. Now we're going to take a look at the posterior view and just see a little bit better some of these structures that we've been talking about. So we've already talked about the head, but now we can kind of see it more fully on the posterior view. You can see the anatomical neck here that I was talking about. You can see that really well on the posterior view. And you can see the greater tubercle really well on the posterior view. You don't see the lesser tubercle really at all on the posterior view. And then the surgical neck is there, and the shaft. We're not going to worry about the deltoid tuberosity. Okay, as you go inferior or distal on the humerus, and you're still looking at the posterior view, it looks a little bit different. You still have a lateral and a medial epicondyle, and you can kind of see them a little bit better, these projections coming out. But the fossa is different. So you've got, instead of having two fossas, you're only going to have one larger fossa or depression here. And it's called the olecranon fossa. You'll have to know that term. And it's called the olecranon fossa because the olecranon of the ulna fits in there to form the elbow joint. And so actually when you look at the point of your elbow, the point of your elbow is actually the olecranon of the ulna. And we'll see that in some pictures here soon. All right, so we're going to move down now to the forearm. So we're leaving the humerus and we're going down to two bones in the forearm. The bone that kind of is on the thumb side of the forearm is called the radius, and the bone that's on the pinky side of the forearm is called the ulna. And so you can see the whole view there, and just as we did with the humerus, we're going to zoom in on a superior portion and look at some structures there, and then we'll zoom in on the inferior portion and look at some views there. We're going to start here looking at the posterior view. So looking posteriorly, there's a couple things we can see in particular. One I already mentioned is that olecranon. So the olecranon is kind of the pointy part of your elbow, and that's the proximal ulna posteriorly. You can see it's kind of large and pointy. You can also see what we call the head of the radius. The head of the radius is interestingly shaped. It's very flat and rounded, almost looks like a disc. Not very typical for the head of a bone. Then right below the head of the radius, of course, you would find the neck of the radius, just like we've seen previously. And then you can see the rest, the shaft of the radius and the shaft of the ulna. So if we, back here, I forgot to mention this joint. So the proximal radial ulnar joint, so the name of the joint tells you exactly which two bones are articulating, the radius and the ulna, and we know that it's going to be up near the elbow joint because it's proximal. So it's near the beginning of those bones. So we're going to see a proximal radial ulnar joint, and then we're going to see a distal radial ulnar joint here in a minute. Keep kind of going down posteriorly, go down inferiorly, still in the posterior view. We'll see a couple of other, actually I wanted to, okay, so as we go inferior down towards the wrist, we will find another joint there in this area. So that's going to be the distal radial ulnar joint. I should just mention here in between, you can see it all the way up, in between the two bones, kind of giving a little bit of stability but allowing for some flexibility, is a membrane there. And because it's a membrane, it's like a loose connective tissue, and it's in between two bones, so we call it an interosseous membrane because it's the membrane in between two bones. So as we go down distally, we can see that there's the distal part of the radius, and both the radius and the ulna have a styloid process. If you look here, there's the ulnar styloid and there's the radial styloid. And remember, styloid just means kind of a small pokey projection, like a spiny projection. The ulnar one is actually much more easy to see and actually is much more commonly broken. The radial styloid is kind of difficult to see. It's just that little bump in there. But the ulnar styloid process is actually clinically relevant because it gets broken quite frequently. Okay, so that's posteriorly we can see. Now if we turn it over anteriorly and we look at the anterior view of the radius and ulnar, we're going to find some other structures that we can see. So here again is that head of the radius kind of looking like a disc. And now we can see the articular surface of the ulna. So this is the part that's going to articulate with the humerus and form the majority of the elbow joint. Remember we were talking about the coronoid fossa because there was a coronoid process, so that's this kind of projection from the ulna has to fit into that coronoid process anteriorly in the humerus. There is a radial notch of the ulna, so on the ulna there's a projection here that articulates with the radius, so we call it the radial notch, even though it's part of the ulnar bone. The neck of the radius we've seen. Just distal to the neck is a radial tuberosity, and similarly on the ulna, there's an ulnar tuberosity. I'm not really making you guys learn those tuberosities, though. Okay, if we go distally and we look over here at this picture, so we're still looking anteriorly now. You can now see the styloid processes a little bit easier. There's the radial, there's the ulnar styloid process, and there's that distal radial ulnar joint that I mentioned before. There's a very unique kind of movement that occurs at the forearm between the radius and the ulnar, the radius and the ulna, and we call that pronation and supination. So the easiest way that I found to remember is supination is rotating your forearm so that your palm faces up and you could hold a bowl of soup in your hand. So that would be supination. So pronation is going to be turning your forearm so that the back of your hand is facing up. That would be pronation. So you see pronation there shows the back of your hand. Supination shows the palm of your hand. What's interesting in pronation and supination is that the ulna, because the ulna is so firmly attached to the humerus, the ulna is not really able to rotate or to twist. It's too firmly stuck to the humerus. But the radius is barely connected to the humerus. It's largely connected to the ulna, and the ulna is connected to the humerus. I mean, it does articulate a little bit with the humerus, but so it is free to kind of twist on itself. And here is why remember I told you how that the head of the humerus was kind of funny shaped? It looks like a disc. Now this pronation and supination is where that becomes important. So this becomes another example of how structure creates function. Because the structure of that bone is funny, is disc-shaped, it allows that disc to rotate in the joint, in the proximal radial ulnar joint, and it allows the radius to twist and actually turn over. So if you look here, see how the bones are kind of parallel to each other during supination. But during pronation, that radius actually twists over top of the ulna, which remains still. So it's really the radius that's moving, rotating. The ulna stays still. Okay, as you continue down the upper extremity, going down the arm, we will leave the radius and ulna, you see here. So this becomes the wrist joint here. And we're going to encounter, the first bones we encounter are these small bones, these short bones, as we learned. And these are called the carpal bones. And there are 2 rows of carpal bones, and each row has 4 bones. So this should help make it easier for you to remember. I would break it up into 2 rows. Call that row 1 and call that row 2. And there are 4 bones in row 1, and there are 4 bones in row 2. Proximally, if we look at the row, what I've called row number 1, and let's start out at the radial side, the first bone that you encounter is the scaphoid. And this is a really important bone clinically because it's commonly broken. I just had one of these in the ER maybe 2 weeks ago. Kind of a middle-aged lady, maybe in her 50s, had slipped and fallen with her hand outstretched, and she had broken that bone right here in 2. So that's a commonly broken bone when you fall with an outstretched hand. The radius bone can fracture then, and that scaphoid bone can fracture. It also is notorious for not healing well, the scaphoid bone, so something that we have to look for carefully. Okay, if we continue over, we have scaphoid, then we have lunate, then we have triquetrum, which is underneath here, and then pisiform, which is kind of this round bone that really sits on top of the triquetrum. If we go to the second row of carpal bones, and again, let's start out here on the radial side. We will start with trapezium, and then see trapezoid, and then capitate, and then hamate. And hamate is one of those bones that you should be able to recognize. If I just gave you a hamate bone on the table, I'm not going to do that, but if I did, it's very unique because it has this kind of hook coming off of it. And so that's easy to identify as the hamate bone. Okay, as we leave the carpal bones, we go to the metacarpals, and you can see that we number those 1 through 5 using Roman numerals. So 1 is going to be the metacarpal that's just proximal to the thumb, and then 2 is going to be proximal to the index finger, and so on and so forth. What's clinically important about the 5th metacarpal bone is that it is the one that's often broken when somebody punches an object. So for example, if you're in a fight and you punch somebody with your fist, it's often the 5th metacarpal that gets broken. And for that reason, we call that kind of fracture a fracture of the 5th metacarpal. We call it a boxer's fracture. I'll tell you what I've seen even more often than somebody hitting another person is I've seen people hitting a wall. Teenage boys, college-age boys in particular, they can get angry, and sometimes they don't think about what they're doing, and they just lash out and punch a wall. And I've seen several boxers' fractures from that story. Okay, now the metacarpal bones are going to articulate with the phalanges right here. And that's a joint, and that's actually what you would call your knuckles. If you make a fist, when you tell someone I'm going to give you a knuckle sandwich, those knuckles, those are called the MCP joints, the metacarpal phalangeal joints. So it's where the metacarpal bones articulate with the phalanges. Those are those knuckles, and those are the MCP joints. So there are 5 MCP joints. Then the phalanges are what we call the fingers. And all of the fingers except for the thumb have 3 phalanges. So we're going to give those 3 phalanges names depending on how close they are to the MCP joints. So the one closest to the MCP joint is proximal. The one farthest away is distal. And the one in the middle would be the middle. So you have proximal, middle, and distal phalanges for each finger. Now the thumb, you'll notice, only has a proximal and a distal. A proximal and a distal. It does not have 3 phalanges, it only has 2. The other 4 fingers have 3 phalanges. So then they also have joints, right? So the joint between the proximal and the middle phalange is called the proximal interphalangeal joint, or PIP. And the distal most joint there is called the distal interphalangeal joint, or the DIP. So you have MCPs, PIPs, and DIPs, and make sure you understand where each of those joints occur. And if that's a little confusing to you, when we get together in lab, I'll help point that out on your own hand even. So here's an example of what I was talking about with that boxer's fracture. So this is the thumb, right? So the thumb, this would be the first metacarpal, the second, the third, the fourth, and this would be the 5th metacarpal. And you can see right here, that bone, this bone has broken off, right? It should be in that direction. So this guy probably punched a wall or punched somebody and ended up breaking his 5th metacarpal, having a boxer's fracture. All right, I'm going to stop this lecture here, and I'm going to call it Appendicular Skeleton Part 1, and then I will upload an Appendicular Skeleton Part 2 that talks about the pelvic girdle and the lower extremities.